Part 3 of the hepatobiliary trilogy takes us to the gallbladder, and there probably aren't as many diseases that we're going to talk about for the gallbladder compared to the liver, but there are still a few important points that we're going to need to take out of this lecture. First up is scanning technique, and because the gallbladder lives amongst the liver lobes, there's really not much different to say here than we had already said about the liver. So remember where it lives. It's between the right liver and the central liver, or more specifically between the right medial lobe and the quadrate lobe. So that's pretty straightforward. When you find the gallbladder, then you should follow the common bile duct caudally because you want to see if it's distended. That common bile duct is adjacent to the portal vein. If you're not sure who's who, you can put color Doppler on the structures and see who doesn't have flow. That'll be the common bile duct. And then try to follow it all the way to the major duodenal papilla where it enters into the duodenum. And you may not see the entirety of the biliary tract because of patient conformation or because of material in the GI tract shadowing over the parts that you're interested in. So what is the gallbladder supposed to look like? What is the common bile duct supposed to look like? Gallbladder should have a teardrop shape. It can be bilobed in cats. The neck will taper and extend kind of into the cystic duct. There's not a clear demarcation between the gallbladder and the cystic duct, and then the cystic duct, which is fairly short, and the common bile duct. Size is quite variable. The gallbladder will be large in an anorexic patient, and then it will empty during and after meals. So depending on how fasted the patient is, you will see different sizes of gallbladder. And so because of that, just looking at the size alone isn't very helpful in determining if there's biliary disease. Wall thickness is reported as less than 1 millimeter in cats and less than 2 to 3 millimeters in dogs, but realistically, you're not going to see it much more than 1 millimeter thick in any normal dog. So for practical purposes, if the gallbladder wall is greater than 1 millimeter thick in either a dog or a cat, you should be concerned about disease or at least an abnormality of that wall. The contents are supposed to be anechoic. The bile is supposed to be anechoic. In dogs, we will commonly see dependent echogenic biliary sludge. Less common in cats, although certainly we do see it sometimes. Most important part, it should move around. It should be gravity dependent. It shouldn't be adherent to walls. It shouldn't be floating or in place in the middle of the lumen. We don't normally see the intrahepatic bile ducts. If you do see them, that's indicative of biliary obstruction, which we'll talk about shortly. The common bile duct and cystic duct, but again, it's pretty short. Common bile duct normally is up to 3 millimeters wide in a dog and up to 4 millimeters in a cat. Any bigger than that, and we're somewhere in the inflammation or obstruction range. As with the gallbladder, the contents of the common bile duct should be anechoic, and we should be able to follow it ideally to the duodenal papilla at the duodenum. Here's a normal gallbladder in a dog. You can see that the wall is virtually, either not distinguishable, or when it is, it's a very thin little line. And then because you have anechoic contents in the gallbladder, you usually will see acoustic enhancement deep to the gallbladder. Sludge is common, and so on this left-hand image, you can see this demarcation between the anechoic bile and this dependent sludge. Sometimes it's kind of in the midst of settling during your examination, and so it may seem a little suspended, but it will fall over time. Those are almost always normal findings. Like I said a few slides ago, cats don't have to have a teardrop-shaped gallbladder. They can be more bilobed, and so you may see this echogenic septum in a cat gallbladder. That's a normal finding, no worries there. Measure the common bile duct. Is it normal? Is it abnormal? So here I've put color Doppler on the right-hand image so you can see that you've got portal vein with color, with flow in it, and then this anechoic non-flow structure must be the common bile duct. It measures at 3 millimeters. Here it is in long axis on the left side. So again, it's about 3 millimeters or so diameter. That's very normal for a cat. And then the major duodenal papilla. This is a little bit more prominent than sometimes we see, but you should see some sort of slightly hypoechoic circular structure along the wall of the duodenum, fairly proximally. Here's the duodenum right there. We've got liver up here. And so you can see that's where the bile duct is inserting. And again, you should always look for it. Is there a mass there? Is there evidence of obstruction from a stone there or anything like that? So moving forward to the abnormalities. I'm talking about obstruction first. Obstruction is just like you would expect. It's any sort of dilatation of the biliary system upstream of some sort of obstructing agent. And you'll see the gallbladder and the common bile duct get enlarged first, and with enough time, the intrahepatic bile ducts will also enlarge and become visible with ultrasound. Usually when there's an obstruction, it's very distal in the common bile duct near the major duodenal papilla, and the gallbladder usually is distended with obstruction. We expect it to be big, just like the GI tract. The stomach gets big if there's a pyloric outflow obstruction. But given enough time, given enough inflammation or fibrosis, the gallbladder may not distend as much as you think it should, and so it can be actually normal size in case of an obstruction. And on the flip side, a distended gallbladder doesn't mean it is obstructed because, again, remember, a fasted animal or anorexic animal may have a pretty big gallbladder. Cystic duct, common bile duct are bigger than those normal values that I had a few slides ago, so greater than 4 millimeters in a cat, greater than 3 in a dog. And again, given just a fairly short amount of time, a few days to a week of obstruction, you're going to see intrahepatic bile duct obstruction or dilation where you shouldn't normally see those ducts at all. And so what that's going to appear is basically too many anechoic tubes throughout the liver, lots of additional tubes that I've accounted for some portal veins, I've accounted for some hepatic veins, and now I've still got these anechoic tubes. I put color flow Doppler on, and there are tubes that don't have flow in them, so they're definitely biliary, and again, I shouldn't be seeing them at all. Reasons for obstruction: pancreatitis is a pretty common one because the pancreas is very close to the common bile duct, and that inflammation can cause obstruction of the bile duct. Any sort of other inflammation of the biliary system, cholecystitis, even enteritis at the duodenum, that inflammation can cause obstruction. Stones of the biliary system. We often see stones without obstruction, but a stone can cause obstruction. So that's important to look for, especially once you're scanning along in the common bile duct. And then cancer, anywhere along the way, can cause obstruction too. So here's a case of pancreatitis leading to biliary obstruction, and we see that the gallbladder is quite enlarged. Again, that's not specific, it could be normal. But when I measure the common bile duct at the level of the major duodenal papilla, I get 4.5 millimeters, which is too big no matter whether you're a cat or a dog. So there is evidence of obstruction in light of that. And in the pancreas, we see pancreas is hypoechoic, the surrounding tissue is hyperechoic, and so that's compatible with pancreatitis. Here's another case. The gallbladder in this case is not particularly distended. It's actually pretty small that you can see in the left image. You would not make many comments about that. I can see the gallbladder wall. I've put calipers on it that you can just barely make out. I didn't give you the measurement. It wasn't particularly exciting. What's more interesting is on the right-hand image, that structure looks just as big as the gallbladder. That's actually the common bile duct. So I didn't give you the measurement, but you can see that it's just, even to eyeball it, it is quite enlarged. I think this one was a centimeter plus. Certainly you'd want to see that number to know for sure how big it was, but this was greatly enlarged and compatible with an obstruction. As we go downstream, again, put color Doppler on the vessel to figure out who's who. There's portal vein with the color. The thing above it must be bile duct. And again, when you measure that, it's more than a centimeter, so that's way too big no matter your species. Definitely indicative of obstruction. Then it's just a question of what is causing the obstruction. And as we go further downstream, basically at the level of duodenal papilla, we see this echogenic shadowing structure with the yellow arrow, and that is our calculus causing the obstruction. Generally, when we look at the gallbladder wall, if there's disease there, we're going to look for thickening and change in echogenicity. So like I said before, a wall should be considered thick if it's larger than those earlier measures. Again, in dogs, it's supposed to be greater than 2 to 3 millimeters to be, quote, big or thick, but in reality, if it's bigger than 1 millimeter, you at least need to start being suspicious that there's an abnormality there. Usually an abnormal wall is also hyperechoic. Sometimes you'll see layers of hypo and hyperechoic, so that can be a little bit variable. Uncommon to see an actual mass of the gallbladder wall, but it's not impossible. Lots of differentials for disease of the gallbladder wall. Edema is common, and those are common cases where we'll see layered appearance, that hypoechoic layer in addition to a hyperechoic layer. Portal hypertension, hypoalbuminemia, anaphylaxis, blood transfusions, you name it, you can get edema of the gallbladder wall. So it's not particularly specific. There are a few things that are more directly biliary related, like cholecystitis or cholangiohepatitis, even pancreatitis kind of getting nearby. But again, a lot of these will look very similar, and so it's difficult to know, is this wall thickening due to a primary biliary disease like cholecystitis, like an inflammation directly of the biliary tract, or is this edema secondary to some systemic process? This is a case of right-sided congestive heart failure. We measured the gallbladder wall. It's 4 millimeters, so way too thick. You can see it has that layered appearance. You've got kind of a bright layer and a dark layer, a hyperechoic layer, hypoechoic, maybe another hyper layer on the outside. So has that appearance of edema. Again, this isn't specific. It could have been cholecystitis, but this patient was in right-sided congestive heart failure, and that was the reason for this one. Here's a case that truly does have cholecystitis. Wall measurement, not overly thick, 1.5 millimeters. Again, kind of that borderline case if it's a dog, and only slightly big if it's a cat. This one is a dog. But what you can see is that the gallbladder wall is very, very, very hyperechoic. It really stands out. So that's abnormal. This one was inflamed. One thing that is very important to identify is a gallbladder mucocele, and that's an excessive accumulation of mucus in the lumen of the gallbladder. It becomes inspissated or immobile, and that will cause problems. It will result initially in gallbladder distension and ultimately can cause necrosis and rupture of the wall. And it can cause obstruction kind of via growth or extension of that plug into the cystic duct and common bile duct as well, and generally does at least cause a degree of obstruction. On ultrasound, you'll see a large amount of echogenic material in the lumen of the gallbladder, and instead of the more normal appearance where it kind of settles out and it's more gravity dependent, here it's centrally located in the lumen, non-mobile. It may have a star pattern, a stellate pattern. It may look more like a kiwi fruit. It's kind of one of the classic textbook patterns. All of those things will raise your concern that this is a mucocele and not just incidental sludge. Usually there's gallbladder distension, although again, that's not a specific finding. And a lot of the times we'll see gallbladder wall thickening and usually an increase in echogenicity as well. The gallbladder can rupture. If it does, that's a surgical emergency. Sometimes, rarely, you'll see a discontinuity in the gallbladder wall, so there you've got your answer. A lot of times you don't see a definitive rent in the wall, but if you have evidence of a mucocele and there's peritoneal effusion around the gallbladder and hyperechoic reactive fat around the gallbladder, then you need to be really concerned that this thing's leaking and you're going to need to go to surgery. The challenge becomes when you have an apparently intact gallbladder, so no evidence of free fluid. You see a mucocele, and you may not know what to do with it because it's not always clear cut. So if a patient came in because he's sick and he's got biochemical signs consistent with biliary obstruction and cholecystitis, he's icteric and so on, then surgery is probably the right answer in most of those cases. But some of these patients come in and they sonographically have a mucocele, but we were scanning them for some other reason and they don't have any clinical signs and they don't have any biochemical abnormalities, and thus the mucocele may be incidental. And in those cases, we may talk about either medically managing for a kind of a suspected underlying cholecystitis, and it's possible we may wait and see. Surgery of the gallbladder is a big deal, and we don't want to go to surgery unnecessarily. And again, some of these patients don't need surgery, and so we may have to just wait it out, or at least conservatively manage their kind of indolent mucocele at that point. Here's a dog who had what we considered a forming mucocele. The dog was, again, getting scanned for something else. No clinical signs that could be attributed to the gallbladder. But he definitely had this more formed appearance of the echogenic material in the gallbladder. It kind of looks like a kiwi when you slice it. You've got this echogenic material with some kind of stripes that go out toward the margins, some hypoechoic areas, again, non-mobile. So this was indicative of a mucocele, but we weren't going to do anything too aggressive for a patient that didn't have any clinical signs. This patient did have clinical signs and has kind of a similar looking appearance to his gallbladder. Thick wall in this case, which the other one really didn't have. Also that stellate appearance, non-mobile echogenic material in the very center of the gallbladder. This is a gallbladder mucocele. I don't see any free fluid around the thing. Maybe a dot right there, but no reaction around it, so it's probably not ruptured. But nonetheless, if he's got clinical signs, then we probably need to talk about surgery here. And then finally, a case with rupture. Here we have, again, echogenic material in the center of the gallbladder. It's hard to see the calipers here, but this whole hypoechoic band is the wall, 6 millimeters. That's way too thick. And then more telling, there's definitely free fluid around this guy, and quite a lot of reaction. You can kind of see how bright it is. It's so bright around the outside here. I'm not even getting a very clean looking image of the gallbladder itself. Again, reactive tissue there. So this is indicative of a rupture of this gallbladder. So that brings us to the end of the gallbladder. As the usual with ultrasound, gallbladder wall thickening is abnormal, but it's not specific as to the underlying cause. And we do see gallbladder mucoceles with some frequency, and we don't always know what to do. If a patient's sick, we need to do something about it. If a patient's not clinically sick, then we have to decide how assertive we want to be about management.